Okay, here's your lecture. This is probably going to end up being in two separate presentations, but your Chapter 11, Childhood and Neurodevelopment Disorders. The introduction to this, we have 75% of adults diagnosed with psychiatric disorders are first diagnosed between ages 11 and 18 years of age. It obviously causes a disruption to the family function, and stigma plays a big role in this. There's difficulty diagnosing younger people because of the limited language skills and cognitive emotional development. So your younger kids especially, it's hard to differentiate between if they just haven't developed the language skills or the cognitive development, their emotional development. So it's harder to diagnose between or before the age of 10 really. Lack of services and premature termination of treatment. Why? Well, because of misconceptions and stigma. Parents don't want to go get their child diagnosed or if medications or continued treatment because there are such misconceptions and stigma and people that just don't want to seek out treatment. So your etiology, genetics do play a factor. You will see that these different conditions that we're going to be looking at all can have a hereditary issue or factor behind it. Neurobiological brain changes during childhood and adolescence. Early adolescence characterized by low emotional regulation and intolerance for frustration. We see that in our teenagers, or remember as being a teenager. They have a hard time regulating their emotions and have a hard time tolerating their frustrations. And this obviously increases through the years of adolescence. So this says psychological factors. You probably can't see the very top of that, but this will be uploaded for you to print. So what is temperament? It is a style of behavior a child habitually uses to cope with demands and expectations of the environment. We have different types of temperaments. We have mild, we have aggressive. I mean, there's all kinds of different temperaments that we can use to describe children. And we've seen plenty of children with the different types of temperaments. So something your book talked about was shyness, aggressiveness, and rebelliousness can be powerful predictors of substance abuse later in life. And I just found that interesting. I mean, of course I did. So I wanted to put it in there just for your guys' FYI. Resilience, we keep coming back to that in pretty much all of our chapters. So this actually gave a nice list of different things that we'll see with resilient people. So adaptability to changes in the environment. So this could be a child that's moving from place to place and does okay with that. Ability to form nurturing relationships. Book said when the actual biological parent isn't there with other people. So, like a grandma or a grandpa or other people, just being able to have those good relationships. Ability to distance self from emotional chaos, good social intelligence, good problem solving skills, and ability to perceive a long-term future. Environmental factors, trauma may be detrimental to developmental periods. And so we've been talking a lot about the different traumas that can happen, especially in early childhood. And if we have somebody in the middle of a developmental period and they experience a major trauma. So the book talked about your familial risk factors. I've said sever, but I mean severe next. Severe marital discord, low socioeconomic status, large families and overcrowding, maternal psychiatric disorders, foster care placement, all can be examples of different traumas that can happen that will affect the environment of a child. Neglect is the most prevalent form of child abuse. 1.7 million reports of child abuse in 2010. 15% were physical, 9% were sexual, and 75% was neglect. So it's a big deal. We've got as nurses got to be watching for our kids that are coming in and trying to determine if there's any kind of child abuse. Obviously, neglect being the top one that we see. And as we've talked before, nurses are required to report suspected abuse. We all remember that the only time that we can't outright just report, and we have to do it anonymously, is when the parent is in a drug or Alcohol Rehabilitation Center. So assessment data for children with psychobiological disorders. Our assessment agency policies typically determine what data will be collected, so that will not be across the board the same things that are always going to happen. That will be something that if you're working in those kind of areas that you will look to your agency policy. But during the data collection process, there will be different things such as interviewing, screening, testing. Genograms was mentioned in your book. I thought that was good to put on there because we just recently worked with a genogram. Play activities, therapeutic games, drawings, puppets, because kids are able to act out things much better than sometimes they can say them. So this actually helps if you get down there with a kid on the floor and start working with them, for you to be able to build a rapport with them and show that they can trust you. We do mental status examinations and then developmental assessments. So I know you guys all just did PEDS and OB before, so the Denver 2 developmental screening test would be an example of that. General interventions for children and adolescents. We have our family therapy, group therapy, behavioral therapy. And in behavioral therapy, we always want to use the least restrictive intervention to ensure civil and legal rights. And we've talked about that a lot in the past too, that, you know, we have to maintain the rights of all of our patients, even our mentally ill patients, actually, especially our mentally ill patients. Cognitive behavioral therapy, disruptive behavior management. So this is the one that is going to include our seclusion and restraints. So I put in there physical needs to be assessed, and on page 187 it talks about vital signs and range of motion monitored every 15 minutes, hydration, elimination, comfort, psychological and physical needs need to be monitored during this because we have the patient in some kind of seclusion or restraints. So we have the timeouts, asking them to go and sit in a designated spot, and then we have the quiet rooms, your psych facilities that are locked typically have quiet rooms. They try to always keep them unlocked, but sometimes they do have to lock them, and then that has to be documented as restraint. So general interventions, you got your little kid there playing, she's cute. Play therapy, child can express thoughts or emotions, because, you know, the kids often do express themselves through their different things that they play with, and especially when they do pretend playing or things like that. Bibliotherapy is literature to express feelings. Therapeutic drawing, illustration of thoughts and feelings that they're unable to express verbally. And kids are able to actually get out a lot of their thoughts, feelings, and tensions that they're not able to just say. Then they talked in your book about music therapy, psychopharmacology, teamwork and safety. They're just little blurbs in your book. Nothing's going to be asked on that part, but the medications, well, yes, there will. The medications that we're going to discuss in a minute here. So communication disorders, you have your speech disorders, problems making sounds. So the kids may say no for snow or lello for yellow. Language disorders, difficulty understanding or using words in context and appropriately. Inability to follow direction. Expressive language disorder, inability to develop skills to communicate verbally or through sign language. And 6% of children have some sort of communication disorder. And this actually hits home for me because I have a child that has a language disorder. Learning disorders, you have your 3 that are listed right here for us. Dyslexia is the main one that we see a lot, or we hear about a lot. The lifetime prevalence of learning disorders is 10%, and learning disabilities account for the largest percentage of children receiving special education services. And special education is no longer what it used to be when we think of special education, especially for anybody who is growing up in the 80s and early 90s. There was a whole different stigma around what special education services are that is not today. Motor disorders. Stereotypic movement disorder is repetitive, purposeless movements. So you'll see a child hand waving, rocking, head banging, nail biting, teeth grinding for a period of 4 or more weeks. So everybody is seeing a child at some point likely with a helmet on their head, and this may be why. It was to prevent injury to themselves. What I found interesting is that naltrexone, a drug that we all just learned about, may actually block the euphoric responses from the behaviors, reducing the occurrence. So I thought I found that interesting. That's a drug that I use a lot at my job. Tourette's disorder, there's a familiar pattern in about 90% of cases. This is motor tics, which is typically physical. And then you'll see the coprolalia, uttering obscenities, is fewer than 10% cases. However, what's been portrayed to us in our society is that the people with Tourette's are screaming cuss words all the time. So the book actually talked about how it's not very common with this disorder. So intellectual development disorder, which was previously called mental retardation, the incidence in our population is only 1 to 2%. And, that's a deficit pretty much all around the board of life. Intellectual functioning, social functioning, and managing age-appropriate activities of daily living, functioning at school, performing self-care. Many times these patients have to have a full-time caregiver. Autism spectrum disorder, as you see on the side, is 4 times more common in boys than girls. You have your neurobiological disability and developmental disability. It appears during the first 3 years of life. The deficits are social relatedness, communication, nonverbal behavior, age-appropriate interactions, developing and maintaining relationships. Other behaviors include repetitive speech, use of objects, over-adherence to routines and rituals, fixation with particular objects, issues with sensory input, and extreme resistance to change. This is very hard on the family. Working with the family and with the child, could be very difficult for the nurse, especially if she or he does not have a whole lot of experience with children with autism, and it's such a family disruption and very difficult for them, so they need a lot of support and reassurance. This says attention deficit hyperactivity disorder, so ADHD. You guys can't see the top of it, but you will on your slide. It is an inappropriate degree of inattention, impulsiveness, and hyperactivity. Most often detected when difficulty to elementary school occurs. So these kids have low frustration tolerance, temper outbursts, labile moods, poor school performance, peer rejection, low self-esteem. Other symptoms may be hyperactivity, difficult taking turns, maintaining social relationships. You can read the rest. So these kids, unfortunately, get labeled with a behavioral problem, many of them, when in reality, they just have an extremely fast-moving brain and need something to slow it down. So boys have twice the rate of incidence than girls. And then if you look at box 11.3 on 195, techniques for managing disruptive behaviors is something that you can read and just know those different things that we can do for that. Drug treatment for this is your Ritalin and Concerta, Adderall and Strattera. So there was a couple of questions here. Which child would be most difficult to diagnose for a neurodevelopment disorder? And obviously, going back to that first slide, it would be the 3-year-old, because we're not able to yet see what their development is actually going to be. And our second one is a 4-year-old frequently lashes out in anger at adults and other children. This child's style of behavior is an aspect of, and this would be their temperament. Because they're lashing out in anger at others. So that would be one of our definitions for the temperament. So, okay, so I'm almost at the 15-minute mark with this one, so I am going to have to put this into 2. So I'll upload this one and then make your next one. Thanks for listening.